I chose to do my evidence-based project on the effect of early warning scoring systems on patient outcomes. I chose my topic and began my discovery searching for information in regards to the rapid response teams and their effects on patient outcomes. I'm new to acute care and I had never worked with a rapid response team before. So during my research, I started finding information about EWS, or early warning scoring systems. Basically, this is an algorithm created that has different information in it, such as respiratory rate, systolic blood pressure, temperature, level of consciousness, things to that effect. The one I'm showing here is the modified early warning scoring system. So the first early warning scoring algorithm was created by Morgan, Williams, and Wright back in 1997. They were trying to aid in the detection of the deteriorating patient in the acute care setting. Gradually, other researchers started doing projects on it, and Stenhall and his colleagues created the modified early warning system, or the MUSE, and it basically works in conjunction with a critical care outreach service, or the CCOS, or something that would be similar to the rapid response team. They also have an MET, or medical emergency team, and it's all geared towards improving patient outcomes. Figuring out that someone's deteriorating and there's a serious adverse event, or an SAE, that may be occurring, such as a cardiac arrest, a respiratory arrest, a stroke, things to that effect. They use this scoring system. You get a certain amount of points for abnormal values, such as like respirations less than 8, you would get 2 points. If your respirations were normal, you would get 0. SBP less than 70, you're going to get 2 points. Temperature of 102, you'll get 2 points. So the score will be higher the more at risk you are for developing an adverse event. And then teams can be activated and resources can be utilized. So my PICO question ended up being, does the use of standardized early warnings criteria protocols to call a rapid response team in deteriorating hospitalized patients compared to no standardized criteria protocol for rapid response team increase positive patient outcomes? So I just wanted to know, if they used a standard early warning scoring system, are they getting better results versus other other facilities or units not using this standardized protocol, whereas maybe just the nurse would initiate it as she's evaluating the patient, assessing the situation, and calling the RRT by herself. To acquire information, I pretty much dug into every database that I could: CINAHL, PubMed, Ovid, National Guideline Clearinghouse, ProQuest, the Cochrane Library, the AHRQ, the RNAO. I even went to the librarian because I was unable to find any evidence-based guidelines. Reached out to the professor as well. Still no actual guidelines that referred to the EWS. There was one that spoke to the RRT, but not in particular to the early warning scoring system. In regards to appraisal, I found about 40 studies that spoke to the EWS, and some were in conjunction with the critical outreach services, or RRTs. I chose 4 systematic reviews to do a critical appraisal of. As I mentioned before, there were no evidence-based guidelines available regarding the early warning scoring system. But the 4 systematic reviews that I focused on had similar goals in regards to determining patient outcomes, like focusing on cardiac arrest or mortality rates or length of stay or admissions into the ICU, and some spoke to the predictability of the EWS. 3 of the 4 systematic reviews were more recently published. One was 2013, 2 were 2014, and the oldest one was in 2007. And all of the studies, in my opinion, were credible after my appraisal of each one of them. To summarize the studies, I had the first one that I did was by Allen. Let me just enlarge this a little bit here. Allen et al. And their purpose was to determine the effect of the early warning score used in conjunction with or without an outreach service on patient outcomes. It was a systematic review with 7 studies. Most of the studies were observational and included retrospective data and did not include control group. The studies were varied in their patient population. So they looked at what happened prior to the initiation of an early warning scoring system, used the data for mortality and for ICU admissions, looking at patient outcomes, and then put the early warning scoring system into place and compared the data from each. They came up with mixed results. They were unable to come to a general conclusion. Trends towards positive patient outcomes with the use of the early warning scoring system were there, but nothing significant. The problem was that varied standardized scoring and studies were not focused on the same endpoint goals, and that produced the inconclusive findings. So some of the studies just focused on mortality, some of them focused on cardiac arrest, some of them focused on the ICU admissions, but their EWS was not standardized. They were different. So it was different EWSs used, meaning some of them used, just example, respirations, systolic blood pressure, level of consciousness, and temperature, and others didn't include the level of consciousness. And then the ones that looked similar had different goal data that they were looking at. So it did suggest, the whole systematic review suggested that further studies would be set up in a larger scale with similar standardized early warning scoring systems and looking for similar goals. But ultimately, utilizing an early warning scoring system did show improvement in patient outcomes, or a trend in it. So that's optimistic, but further studies need to be done. The second one I looked at was Mapp et al. And they did a systematic review. They reviewed 9 studies between 2007 and 2012 that talked about the early warning systems and the clinical support systems. The majority of the studies were retrospective with pilot programs, including the initiation of the EWS, but using it, calculating the scoring through the electronic medical record. So as the nurses inputting vital signs, the values are popping up and calculating the early warning scores. These studies were all done on adult med-surg units, and as I said, they were retrospective, so again, using data from before the initiation of the early warning scoring system to data after the initiation of the early warning scoring system. Utilizing the EMR and the early warning scoring systems in their various versions in conjunction with support systems such as RRTs did show improvement in patient outcomes through this systematic review. So basically setting up integrated care systems that utilize the EMR, electronic medical record, and early warning scoring systems improved patient outcomes. The third systematic review that I looked at was McGoffey and et al. The purpose was to determine the impact of the outreach services that included the EWS on hospital mortality rates, and the secondary objective focused on specific patient outcomes such as ICU admissions, length of stay, the number of adverse events before and after the introduction of the early warning scoring system. This was a systematic review of 2 studies. One was a randomized control trial on examining 12 hospitals with outreach services to 11 hospitals without the outreach services, and the second study compared 16 medical wards. 8 had the outreach services and 8 did not. The studies did not show a consistent improvement in patient outcome, including cardiac arrest, ICU admissions, or length of length of stay. And then one study did show an increase in the calls for the RRT, or the medical response team. So that was a positive outcome, because utilizing the early warning scoring systems, they did see a rise in the reaching out of nurses when they detected deterioration in a patient. So they were getting more services, but unfortunately they couldn't tie the increased use of the RRT to improved patient outcomes. The fourth systematic review that I looked at was done by the Veterans Affairs, and it was very, very in detail and thorough. They have a thing called the Evidence-Based Synthesis Program. So they review evidence and then they try to synthesize it into practice. It consisted of 3 focus questions. The first question was in regards to the predictability of the early warning scoring system. How well did it predict changes? And that was somewhat inconclusive, because although a high early warning score did show deterioration in patients, having a high score didn't always mean that you were going to deteriorate, but having a low score didn't mean that you weren't going to deteriorate. So it did show that deterioration was imminent in some people, but just because your score was high didn't mean you would deteriorate, and just because your score was low doesn't mean that you would deteriorate. Would not. So not conclusive in regards to predictability. Then the second question was focused on patient outcomes in relation to the use of the EWS. Again, this was not conclusive, and they suggested further studying. And the third question was intent on determining the impact on resources, meaning nursing utilization and staffing needs. There was an increase in the use of resources while using the early warning scoring systems. So just as the one done by McGoffey, they did see an increase in the RRTs being called, and nursing staff such as ICU staff and whatnot being utilized, because the early warning scoring system triggered the need for more skill or more care. So applying this, the general consensus from all 4 of the systematic reviews that I used suggested the need for further studies. Just needs to be more homogeneous so that they can compare and get better data, and hopefully get some significant data showing that one early warning score system works better than the other, or in a particular way that they utilize it, whether it's with the EMR or not. But they need further studies. There are no evidence-based guidelines in regards to the early warning scoring systems, so they need to work on the studies in order to come up with the evidence-based guidelines. And whether a facility or unit utilizes a standardized or customized early warning scoring system, the studies tend to lean towards improved patient outcomes. So it's something that we definitely need to move forward with. We need to focus on getting more research and coming up with some standardized scores, but just because there isn't any guidelines out there doesn't mean that it shouldn't be used. And seems like a lot of places are just customizing towards their own patient population and what works for their facility. Like I said, there are positive outcomes, but they're not always coming up as significant because of the varied ways in which they do the studies. So translating this to practice, local area hospitals and or hospitals that are affiliated under umbrella corporations like Catholic Medical Centers under Granite One, and they work with Huggins and Monadnock, and so that's what I mean by umbrella corporations. They need to work in conjunction with one another and implement standardized critical care outreach services that include standardized early warning scoring predictive values. And once they do that, then they can do some larger scale studies and conduct them in the pursuit of similar data outcomes. This data will be helpful if it included mortality rates, length of stay, and utilization of the outreach services. And if the studies are not feasible, the use of the early warning scoring systems and the critical care outreach systems do suggest the potential for improved patient outcomes and should be implemented. Be aware of the deteriorating patient. Obviously, we want to make sure that if something's going south, that we catch it before we start doing a code blue. With more focused studies, we can integrate standardized early warning scoring systems, and we can come up with some guidelines so that best practices can be developed. Continued evaluation of the data related to the patient outcomes will help determine if the use of the standardized outreach service, including the EWS, is effective in improving patient outcomes. This can help improve the length of stay and prevent negative patient outcomes before they occur, and will improve financial outcomes. And determining the most essential needs for utilization of nursing personnel can also improve patient and financial outcomes for the facility or organization. So basically, we need to do some more research on this and standardize what we're researching so that we can come up with some significant data. When the data is all over the place and these people are talking about length of stay and the other people are talking about ICU admissions, and they both have different early warning scoring systems anyway, then it's really hard to tell what is the best algorithm to use. Should it be incorporated into the EMR, or is it better to do it on paper? There were several really interesting studies and ideas, but it really needs to be standardized so that we can come up with the best way to be aware of the deteriorating patient. Thank you.